Thank you very much for the invitation. I will present several cases, and in each case I'll try to focus the issues that we were challenging, and maybe also do a discussion during the presentation to see what the crowd would do. So we'll start. How do I go here? Okay, we'll go from here. So we know that the conventional TEER indications are for patients with primary MR that are considered high risk for surgery, and for patients with secondary MR that are good candidates. We presented before what is the ideal patient for a clip. However, we also know that the TEER procedure has many advantages. It is very safe. It often gives you an immediate hemodynamic effect, and might be that other high-risk population might benefit from the procedure as well, not only the conventional TEER population. So I'll present the first case. This is a 73-year-old man with HOCM. He has chronic heart failure for many years, and he deteriorated recently. Has a good LV function. The interventricular septum diameter is 21, not a huge interventricular septal diameter. He has moderate to severe MR. He started with the moderate to severe, it became more severe. He has an LVOT gradient at rest of 115, and during Valsalva 176. He has no coronary disease. And the main pathology of this disease is severe SAM, severe systolic anterior motion of the valve. We can see here the combination of severe eccentric MR, which is the hallmark of SAM-related MR, and of course the movement of the anterior leaflet blocking the LVOT. We have the classic LVOT obstruction due to the SAM. And the patient, it was before the mevakamtan area, I must say. Now we have the mevakamtan, it might change anything, but it was before of it. We can see here deep reversal of the pulmonic vein pattern. It's also very important. It's not just, yes, you have reversal of dot. The extent of the reversal is also important in those patients, a deep reversal in the pulmonic vein. And what is the best therapy for this patient? Myectomy, ablation, surgery. This patient, the septum is not very thick. So he's not a very good candidate for surgery. He didn't want also go for surgery. He was not a candidate for septal ablation because of the septum. And we thought that we might offer him something else. So we offered him a TEER procedure, with the aim of the TEER procedure is to eliminate the SAM. And by eliminating the SAM, you can get two benefits. You can improve the MR, and you can also alleviate the LVOT. And this is one XTW in the middle of the valve. Very easy procedure. You have a long leaflets. You aim for the SAM area. And by one clip, you can see here also that the flow in the pulmonic vein became systolic dominance. There is no MR because all the MR was SAM-related MR. And this is the hemodynamic immediately after TEER. This is a gradient before the TEER and immediately after the TEER, which means that one XTW in the middle of the valve helped you to get an excellent result. So this might be a pattern for patients that are considered high risk for surgery, not good for septal ablation, and that the MR is mostly SAM-related MR. Important tips for the procedure. In TEER procedure, we are always aiming for the jet. In this procedure, aim from the SAM. Ask your echo, where is the most prominent SAM, and put the first clip there, and try to eliminate the SAM. You might require more than one clip in several cases. Be aware of the gradient, because those patients are not really tolerable to the gradient because of their LV hypertrophy. And it's very interesting during the procedure, how do we make the MR more prominent during the procedure? When we want to evaluate our result, we tell the anesthesiologist to increase the pressure, right? Opposite in this case. In this case, when the MR is SAM-related MR, you need to decrease the blood pressure to see the MR. So this is the 3 tips and tricks for this first patients. So this is, we published also our data, and it's also written about the mitral valve intervention in general in patients with hypertrophic obstructive cardiomyopathy, highlighting the potential role of TEER in those patients. This is another case. The 90-year-old woman that came with sudden pulmonary edema. And we can see here the valve. Very challenging valve. We can see MAC is prominent, is circumferential. It also has a shelf of calcium just above one of the posterior leaflet. And we can see here flail. You see that there's a jet there. There's also flail with severe mitral regurgitation, but there's a lot of calcium that might limit your ability to grasp the leaflets. However, she was 90. There was no really options for her. Not for surgery, not for a valve in a MAC or something. So we decided to try and do a clip on her. So we went with the one device, we go below the MAC, then went anteriorly to avoid the shelf of the calcium. And after we grasped the anterior leaflet, we went posteriorly and went and got a grasp. So this was the result. You see the one clip in the middle of the MAC. Those patients are not good candidates, not ideal candidates, but TEER can be life-saving in these patients. Imaging can be challenging. Sometimes in order to evaluate the grafts, you need to go to the transgastric, similar to the tricuspid, because you have shadow of all the calcium if you go from above. But transgastric may allow your grasping. To avoid the MAC, you need to do independent grasping. Go very anterior in the first one, get the first leaflet, and then go posterior. And of course, be aware of the gradients. Those valves sometimes get high gradients. So this is the second case. Now we'll go for the third one. This is a 70-year-old man with no significant cardiac history, presented in STEMI and cardiogenic shock to another hospital in Israel, located in the south part of Israel, 90 minutes drive from my hospital. And there was no cardiac surgery service in this hospital. And then they took a picture of the TEE that they've done on the table. We can see here papillary muscle rupture. We can see the head of the papillary getting into the left atrium with severe mitral regurgitation. So what would you do in this case? Any suggestion?
I think because it's a fantastic case. We had that also, and it does indeed help in the acute constellation after the vessels are done to consider TEER.
Okay.
It's something that it can be done if the patient is going in direction cardiogenic shock and is unstable. It can be considered if the patient is not stable.
I will tell you, Moni, what would happen in Greece.
What would happen in Greece?
It will happen MTR, almost definitely. So maybe in a couple of centers when you have the possibility of doing ad hoc MTR, yes, you might do that, but in the majority of the cases, the patient would have to undergo a surgical procedure or nothing.
Okay. So we asked the staff there, bring the patient. And then they told us, we cannot bring him because he's not transferable. We cannot bring him. He's on impella, we cannot do anything. With an intra-aortic balloon, sorry, he's not stable, we cannot transfer him. So no surgery, they cannot transfer him. So we went there.
Seaport method. The interventional team travels.
Right. You see? Mobile TEER team. for acute post-MI infarction mitral regurgitation. You can see here the cath lab. This is myself there, the interventional cardiologist that came from the tertiary center. We came an echo guy, myself, and few extra stiffs, not really difficult thing to gain in a cath lab, right? There is no post-op for this, right? Just to press if you need on the groin. So it's classic. Instead of bring the patient, come to the patient. This is a mobile TEER team. This is how it was performed from the presentation at 5 a.m. in the morning until the TEER that was finalized at noon. And the patients, this is one clip, grasping all the flail area of the papillary muscle. The MR went down from mild to moderate immediately. Immediately the blood pressures went up. The anesthesiologist always said, what happened now? So, oh, we just clipped the valve. And the patient was discharged from the CCU after 7 days and went home. Yes.
This is fantastic that you're showing that, because I think these pre-cardiogenic shock patients with STEMI and this constellation with ECMO, even with ECMO and unstable, they really benefit from that.
Right.
It's fantastic.
So this is our data of patients that we have a registry of post-MIMR. This is data of patients that had papillary muscle rupture. We know that those patients are difficult to treat. Technically, sometimes the valve is very mobile, especially the area of the rupture. Sometimes you need to put a device just close to the area just to stabilize the valve and then add another clip. Small atrium. Sometimes you need to do all the manipulation in the ventricle. So you need to be very careful opening in the ventricle. You don't have the classic evaluation in the atrium. And don't aim for perfection in those patients. Just stabilize the patients. We know that 30% of those patients will require definite surgical intervention after they get from their condition. So this is the third case. And for the last one, okay? 71 years old woman, dilated cardiomyopathy due to breast cancer, hypertension, obesity, and diabetes. We'll do it as a discussion, okay? You can see here, functional MR. We can see poor LV function, right? Functional MR, severe, functional, wide. We can see that the leaflets are not calcified, very thin, but long. Okay? We can see the length of the posterior leaflet, very long. We can see the 3D wide jet. Okay? So we went for a clip. What clip would you use?
Well, to be honest, these are cases that probably could benefit from Carilion device and clip afterwards.
Okay.
As a combination, because it's this really wide jet in the middle. The annulus looks like dilated, so that would be probably the way we would try to solve it.
Nice. We don't have the ability to put any annuloplasty device. We don't have it in Israel. So we decided to go for a clip immediately, not immediately, go straight to clip. Which clip would you use? Or other device? Would you take an XTW because of the long leaflet?
We have to consider secondary leaflet detachment also sometimes. I mean, this is a big question that you're raising. I mean, what about leaflet detachment on the basis of the annulus and tension that can be applied?
We'll see.
Well, how about Pascal?
Pascal might be a good option. We took an XTW in this because we said, okay, the long leaflets, we can grasp it. So we put the first device. You can see that the grasp is, you can see that the leaflets are laying very smoothly on the valve, and we got a good result. This is after deploying, and then we decided to add another one because we had a jet that was lateral to the first one, and then we put the second one with an excellent result. Okay? The day after, the patient went home, in excellent condition, mild trace MR. Any comments on this case? Everyone's happy.
Very good.
Okay. 2 weeks later, I get a call from the ER. Your patient that you did a clip on her 2 weeks ago came in pulmonary edema. Okay? We can see here severe mitral regurgitation. We see that the clips are not detached. Both of them are standing, but there's severe mitral regurgitation.
On the basis, the annulus.
And now we are going for a TEE. Again, no single leaflet detachment, no detachment of the clip, but there is a huge jet just close to the clip. And this is a 3D, and you can see here tear of the anterior leaflet.
Yeah.
So these patients, although we get an excellent result during the procedure, underwent surgery after the procedure because of late tear of the valve. So this is an important thing to know. We just published our data about mitral leaflet tear after TEER. 1 month ago in the Canadian Journal of Cardiology, we collected 4 cases from our data that was almost 700 cases. In all cases, the tear occurred in functional tethered leaflets. In 3 of the cases, it was immediately during the procedure, and in this case was 2 weeks after the procedure. In all cases, the tear occurred after the second device was implanted, including those that was during the procedure, suggesting that there was too much tension on the leaflets. Be aware of too much tension. It might be related to bigger T device in patients with functional, especially thin leaflet like this woman, young woman with a lot of tethering. Be aware of too much tension on the leaflets. So these are the 4 cases I wanted to present. TEER remains a more versatile technique in wide range of indications. However, there's not much of data of those cases, HOCM and all of those. Further prospective research is definitely necessary to reach a conclusive data. This is an expert review that we published recently about out-of-the-box or evolving indications for mitral TEER in neurointervention last year. Thank you very much.
Really excellent, really cases. It was really fun to watch. I just have a question, and maybe I think I would add something on top. What about, because I really have cases of exactly the same problem about 3 months after TEER, but with patients with a really big flail, when you use a really big and long clip. So this problem can also occur 2 or 3 months later in case of massive flail, when you really grasp a lot of tissue.
Okay.
So the secondary aspect of that, probably with patients that have delayed left ventricle and have a recompensation at home, volume plays a role. I think it's an issue that also can play a role. What's your opinion about that? Like really,
I think that
patients.
in general, this is an unreported issue. When I looked on the data of them, maybe 1 or 2 cases, I don't believe it. There's a lot not a lot, but there's more cases. We do not really understand them. What is the mechanism of them? We do not really know how to prevent them, especially the late cases. And I think that this requires more data in order to evaluate the mechanism of this.
It probably has to do with the consistency more so than the dimensions of the leaflet. So it's a little difficult to know that, because we measure the length, the this, the that, but is that a paper thin?
Right.
Or is it like the silver paper of the old cigarette boxes, or is it hard like this? Or we don't know.
I think that maybe I spoke with the companies, maybe devices that can evaluate the tension on the device itself might help you in those cases. You cannot predict. You
Right.
cannot really predict.
Well, and another thing that may be a little related, not exactly a tear, but sometimes when there's a combination of a secondary and primary, you get some kind of unpredictable infolds. So you grasp, but because you grasp, there is kind of a funny fold, and all of a sudden you have like a hole, which is not a hole, but it's like a funny infold or whatever you want to call it.
Right.
It's the non-grasp leaflet is big, so it kind of deformed.
Right.
So whereas you thought it's in the center, after the infold, funny things happen here and there, and that's exactly why you have to be reactive in the procedure. And sometimes it's a little bit of a conundrum. Do you accept that? Or if you grasp it, maybe it's too much, you have a gradient, so you may end up having a little bit of a problem, totally different from what you were anticipating.
Right.
Thank you very much for your excellent presentation. In the first case, you proposed, if I'm correct, a new therapy for HOCM.
Right.
How many patients? These are very difficult patients and difficult to handle. How many patients have you do with this?
So I think that the ideal patient is a patient with prominent SAM without a very thick septum.
So borderline thickness, and somehow unexpectedly severe SAM MR kind of thing. So combined still, but not the opposite. If it's the moderate MR with a major septum, that would not be a good case.
Right. And he should be on therapy because unfortunately mavacamten can be very efficacious in preventing it. We saw patients that had severe SAM, and after treatment with mavacamten, the SAM was eliminated.
Yeah.
So patients that are on medical therapy, including mavacamten, severe SAM, high risk for surgery, not a huge septum, are good candidates for this.
One more question, and we can get Dr. Chatzitofi getting ready as well for her presentation.
Yeah, truly innovative.
Sorry. Did you have any experience of
Dr.
immediate?
Shuvy, join us on the podium
Sure.
here so she
Sorry.
can set up. Go ahead.
Do you have any experience of immediate TEER during the first attempt? We have one case in an 81 years old lady. We changed the position 3 times with the first clip. It was degenerative, plethoric, but degenerative, not functional mitral valve, and it was ruptured. She went immediately to surgery.
So it's important to understand what tear do you have, because we sometimes tear a cord. If we tear a cord, sometimes we can fix it during the procedure. But if you have a tear of the leaflet itself, not really a good option. We don't really know exactly how to predict. But as you said, when I looked on the literature, it was very difficult to find those cases. But now in 5 minutes, you are telling me one case and you are telling me another case. So
There are there. The more you look, there are there. Yes.
there are there.
Go ahead. Last question.
Yeah, really quickly, truly innovative stuff because we hate MAC as surgeons and to see, and it's our cardiology colleagues on the heart team that actually say, no, I don't want to do the MAC because the MAC is often associated with a low MVA. So below 4, they're worried, below 3.5, it's a no. So we're, begging the cardiology colleagues on the heart team to do the MAC with an M TEER. So congratulations.
Yeah.
Thank you.
Okay, let's go ahead with a live inbox and